Morning everyone. Hope you're well. Thank you, Steph. Yeah, I had a good time. Thank you. It's one of those. As soon as you're back, it feels like you never went away. Welcome back. So yeah, we had a look a couple of weeks ago at spinal discs and the structure of the discs, and we looked at herniations, and that leads quite nicely then into this session, or the next couple of sessions probably, depending on how we go with time. So we're going to have a look at the structure of the spinal cord, how messages get passed up and down the spinal cord, and then once you understand that, then hopefully it will make a bit more sense as to why things sometimes go wrong, and how to spot different things. Sometimes it's not easy, and we sometimes we don't know, but there are some kind of signs and symptoms that are really key to look out for. So we're going to have a look at those. We're going to have a look a bit at the pathology of the region as well. So that's the plan. So first thing today is we're going to have a look at the structure of the spinal cord itself. And yeah, if you deal in any kind of therapy and lower back pain, that kind of thing, then this session these next few sessions are going to be really crucial to get your understanding of why things happen the way that they do. So and it's one of those things. Again, one of the reasons why I put Learn Anatomy Online together was because I felt that some of the teaching that I had didn't give me it didn't explain things simply enough. I know things are complicated, and there sometimes isn't a simple explanation, but I think it lacked some of the detail, I think, that we're going to go into now. So, and then once you know this detail, then it starts to make a bit more sense. So so that's the plan. Morning, Tris. Good to see you in, mate. And Martin as well. Good morning. So yeah, so we're going to have a look at that today. So first thing, we're going to split the spinal cord into two sections. So we're going to do gross anatomy, and then detailed specific anatomy. So yeah, whenever a slide that I've produced, or a series of slides that I produce, say detailed anatomy of the spinal cord, there's going to be quite a few quite a few slides, so bear with me on this one. I will intersperse it with some of the video so that you can see the anatomy that I'm trying to describe on the slides, and see it in real life as well. So that is the plan. Just get rid of that. Okay, so here we go. Some of the stuff we already covered. And we've got these the curves of the spine we've already had a look at, the vertebral column, the fact that there are different sections of the spine. So the upper part of the spine is the cervical region, the mid part here is the thoracic region, then we've got the lumbar spine, and then we've got the sacrum at the bottom just here. So we've had a look at that previously when we looked at the bones and joints of the lumbar spine, especially, and we're going to focus on the lumbar spine as well. The spinal cord changes throughout the spinal column. And we will allude to that, but when we get to those regions, there are some specific structures that come out of those regions. So there's specific stuff in the lumbars. We've already had a look at the lumbosacral plexus. So this is kind of going back into where that originates from over the next couple of sessions. But in the thoracic region, there's a host of kind of neural networks going all over the place. So it's completely different to the lumbar spine, completely different to the cervical spine. So that will cover in a section all on its own. So yeah, we're focused on the spinal cord, but mainly this lumbar region, which is what we've been focusing on. So obviously the vertebrae are stacked on top of each other. We looked at the spinal disc a few weeks ago, and the makeup of that disc, how it maintains its integrity, how it starts to degrade over time as well. And we looked at and we're going to recap some of those things today as well, because that links into the problems with sciatica. Okay, so in invertebral combo sciatica. So we'll explore that term in a bit more detail as well. Hopefully we'll be able to get to that today. If not today, then definitely next week. So we've got vertebral foramen down the center of the spinal column, and that's to protect the spinal cord. So if you look top down on the spinal column, there is a hole, the vertebral foramen. Foramen just basically means a hole, and that's where your spinal cord goes through. Okay, so the spinal cord is encased in the bony structure of the spinal column. Okay, we've got intervertebral foramen on the sides at each level, and this is where the peripheral nerve emerges. So peripheral means outside. So we've got central nerve or central nervous system, which is the brain and the spinal cord, and then the peripheral nerves are the ones that then come out. So as soon as they come out, they're then peripheral nerves, and we're going to talk about those as well today. And that the understanding of the structure of those will then start to make sense with some of the things that can go wrong as well. Okay, so we've got split into regions. 7 cervical vertebra, 12 thoracic, 5 lumbar, and then between 5 sacral, and then between 3 and 5 coccygeal. And then again, we've looked at this as well. There are anomalies in this region, and sometimes you can have 6 lumbar vertebrae, sometimes 4 sacral vertebrae, sometimes 6. So there are some variations, and this was a few episodes ago. Talked about those variations. So sometimes people will have an anomaly that is entirely normal to them, and that is the reason why sometimes when you're feeling something and you're expecting something to move and it just doesn't move, so you think it's restricted, you mobilize it or try to get it moving, but actually it's just that they have additional sacral vertebra and they're fused. Okay, so they're never going to move. So that we need to be aware of those anomalies, and they're more frequent than you think. But we wouldn't know unless you've had some imaging done. And then usually you only have imaging done if you've got pain. So if someone's not in pain and it just looks a bit funny, then it might just be them. Okay, so you need to take that into consideration as well. Okay, so when we start to look at the central nervous system, just move me out of the way there. We've got something called meninges, and you might have heard of a condition called meningitis, which is basically an inflammation of the meninges. And so inflammatory chemicals will enter the meningeal space, and as we know, it can be life-threatening. So it can be a really serious condition that needs to be dealt with really quickly. And one of the reasons is that it spreads so quickly is because of these meningeal layers, and they are continuous with the spinal cord. So they surround the brain, and they're like wrapping. Okay, so we've got layers of wrapping around the brain, and then that wrapping then comes together and then comes down the spinal cord as well. So it's continuous with the cord. So this is why if there's any inflammation along any part of the wrapping layers, then it can spread really, really quickly. And one of the tests that you can do for meningitis is the tumbler test. You might have seen that. If you've not seen that, then you can have a look. It's especially concerning with kids. Okay, so but obviously it can affect adults as well. And yeah, it's something that needs to be dealt with very, very quickly. Otherwise, you can be in a lot of trouble. So we've got protective layers around the spinal cord, which also extend to the brain. Okay, so here, let's have a look. So we've got the periosteum, which is the connective tissue around bone. So where things are able to then connect to the bone. You've got the cranium here, so this is the skull layer, just here. An aponeurosis layer, which is a connective tissue. And then we've got the scalp on the top. Okay, so we've got these layers above the bone. Underneath the skull, we've got these three layers, and these are the meningeal layers. Okay, so we've got the dura mater, which is the tough mother. Okay, so durable mother, mater means mother. The arachnoid layer, which is like a spider's web. Okay, hence the name. And then the pia mater, which means delicate mother. So we've got this very delicate, fine connective tissue. So each of these three layers, they sit on top of each other, and they form the protective layers for the brain and the spinal cord. And we'll have a look at that in a sec. Yeah, here we go. So dura mater is tough mother, arachnoid mater, spider mother, and then pia mater is your delicate mother. So it just describing the kind of structure of those specific layers. Okay, so they wrap around the spinal cord like a mother's protective cuddle. So that's why it's been given the name, each of the layers a mother. Okay, so yeah, so we've got these mothering layers that surround the spinal cord all the way up, surrounding the brain as well, all continuous. Okay, and yeah, it surrounds everything. Yeah, so if you've not heard of that before, then that's really important for understanding meningitis. Okay, so let's have a look at that a second. Here we go. Okay, so these are some of the so that this is your spinal cord from a spinal column, sorry, from a top-down view. This is a thoracic vertebra. And the just because of the shape of it, you can tell this is the vertebral foramen that I was talking about before. So that's the hole in the middle where the spinal cord goes down. Transverse process, spinous process. Okay, and we know that this is a thoracic as well because there is a little indentation here and a little indentation here, and that's where the rib attaches and comes around. Okay, so that we've got these little what we call facet joints on the transverse process and on the body where the ribs attach, but we'll talk about that when we get to the thoracics. So that is a thoracic vertebra. Let's have a look at what goes in the middle of it, and there it is there. Okay, so this is how your spinal cord will sit, and obviously it's not just empty. This is obviously a cadaver that's been where the fluid has been lost, but this will be surrounded with fluid. Okay, so you have cerebrospinal fluid all in here, surrounding the spinal cord to cushion it from any kind of sudden movements. So we can see the cord here. And let me just rewind that a sec. Just get that. There we go. Cool. So you can see slightly in the middle there. We're going to have a look at this in a bit more detail as well. But we've got this grey matter in the middle, which looks like a butterfly effect from the top down. So if you chopped a spinal cord, that's what it would look like. And then we've got the white matter on the outside, on the edges, and you can just about make that out on this dissection here. But that's something that we'll have a look at in a second. Here they've got a pair of tweezers, and they're just going to pull on the side of the spinal cord just to show you the layers. Okay, so I'm just going to have a look at that. So there it is there. So we can see these, you can pull it across there. There's your nerve roots just popping through there. We'll have a look at those in a bit more detail later as well. I'll just go back a sec. So I'll introduce you to these, but we're going to spend quite a bit of time talking about nerve roots. So we've got a ventral nerve, which is one that is at the front. Okay, so ventral is anterior. and then a dorsal nerve, which is towards the back. And the reason why I've got a picture of a orca is the dorsal fin. So that's the way to remember which way is which. So the dorsal is on the back, which is where the dorsal fin is. Obviously, we don't have those, but for some reason, rather than calling things posterior, still the name dorsal persists in this particular region. So we've got the dorsum of the foot, and we've also got the dorsal nerve, okay, or a dorsal, kind of section of the nerve, if you like. So dorsal is posterior, ventral is anterior, and you can see where these nerve roots come off of the spinal cord, and then they'll merge together as they exit the through the intervertebral foramen. But again, we'll talk about that in a bit more detail later. So yeah, we've got this layer around the spinal cord, but then these are the meningeal layers as well around here. So we've got the dura mater, so this is the durable part, the tough mother. Then look at that, yeah, so you peel that away, and then we've got this arachnoid layer, and then around the spinal cord itself, that's the delicate mother. So that's protecting the spinal cord itself, and all around here is usually filled with cerebrospinal fluid. Okay, so we've got this dura mater on the outside, arachnoid layer just inside that, and then the pia which surrounds the spinal cord itself. And then the cerebrospinal fluid, if we have a look on this image here, it covers all the way around the brain, around the brainstem, and then down the spinal cord. Okay, so like I say, if that gets infected, cerebrospinal fluid gets infected, then it can just travel through the whole system. Okay, so again, that's why meningitis is such a dangerous condition. Okay, so then we've got a subarachnoid space and an epidural space, and you might have heard of an epidural injection. Okay, and this is basically where they apply an anesthetic into that space, into that epidural space. Let me just go back a sec again. Okay, so cerebrospinal fluid. Ooh, press the wrong one. There we go. And then epidural upon the dura. And that's where they're aiming for with an epidural. Cool. Okay, so that's basically what we were just talking about there. Okay, but rather than being around the brain, we saw it as it's around the spinal cord, which is obviously useful for us over the course of the next couple of sessions. So this is basically what we've been seeing on that particular image. So we've got the dura, which is the most superficial, continuous with the brain dura. Again, it wraps around everything from brain and spinal cord, attached to the outer of the spinal cord. Okay, so we've just seen there, there's a bit of a space in between. Then we've got the arachnoid, which is the middle meningeal layer. It looks like a spider web, hence the name. Between the dura and arachnoid is interstitial fluid, so there's some fluid in between that layer as well. And then the pia mater, innermost and thin layer, contains the blood supply for the cord. Joins with the arachnoid and dura to form the denticulate ligaments. So that's these here, and we'll have a look at those when we look at the cord in a bit more detail. So denticulate ligaments, they're called that because they look like teeth. Okay, it's like dentist. So and what they do is they hook on to the connective tissue so that the spinal cord doesn't move. Yeah, so we've got these projections that come out and hook in. Otherwise, it will move about as we move. So these give us some stability of the cord, so it doesn't move too much. Joins with the arachnoid and dura to form the denticulate. There we go. And then the space between the arachnoid and pia contains cerebrospinal fluid. So that's what we've just seen on that particular video. Okay. So yeah, this is what it will look like on a cadaveric dissection. And if you have been to the labs with me, then we've seen these kind of specimens, and you can have a look at the cord as well, and the grey and white matter of the cord. Everything is there. I think people are often quite surprised at how I don't know, kind of the structure of it really, and that I think they think it's a bit more delicate because it's quite tough. Yeah, it's quite a tough piece of connective tissue. So I mean, it has to be with what it's protecting. So it's basically it is like this. So we've got the outer layers, and then we can see that dura here, and then that then forms. So see where the nerve roots come off here and here. Yeah, and then they come through to form this nerve root here, and then that becomes the peripheral nerve. So the nerve roots are protected by the dura as well as it passes through, and we'll have a look at that in a second. Now, interestingly, well, I think it's interesting. In newborn infants, the cord fills the vertebral column all the way down to L3, L4. Okay, but in an adult, it stops around here. So the spinal cord finishes at around about L1, L2, and that is called the conus, okay, or the conus medullaris. And if you have an MRI report about someone's spine and spinal cord, they will often comment on the position of the conus, and they'll say that it's in a kind of normal position. Okay, so the conus is lying in a normal position, and the reason why they say that is because there is a ligament that attaches on the end of the conus that comes all the way down to the coccyx, the filum terminale it's called, and that filum terminale anchors the spinal cord in position so it doesn't ping up. Okay, so we've got the denticulate ligaments that hook on, plus the filum terminale, which is this piece of connective tissue, the final terminal basically, so it comes all the way down into the coccyx, and then that anchors it in place. So if you fall on your coccyx and fracture the coccyx, then it can disrupt that filum terminale, and then the conus will move, and then that will stretch all of the nerves here. Okay, so that's one of the reasons why they check it, and they want to see if it's lying in the appropriate place, which should be around about L1, L2. Okay, so the filum terminale arises from the conus and attaches to the coccyx, and it anchors the cord in place. Okay, so that's what that is there. If you've not heard of that before, let me just quickly show you this. Just do this one. Okay, so similar kind of view to what we saw before, but we're going to have a look at a bit kind of wider view first. So these are the spinous processes down the back. They've now all been removed, and this is the cord in situ. So there it is there. And what they've done is they've made an incision, well, they will do in a second. They'll make an incision down the dura and then open up the dura so you can see the cord behind. So if we give that dura a bit of a pull, so that's the connective tissue surrounding it, the dural sac. And in fact, if I just go back a sec, when they pull it, you might just be able to make out, I don't know whether you can see there and there, those are where the nerve roots are coming out. So the dura surrounds those nerve roots as they exit the spinal column as well. Yeah, so that's a good one there. You can see it just there. So there's the base of the skull. So the foramen magnum at the base of the skull, and this is the dura that's continuous. Yeah, so you can see it going up to the brain. So the foramen magnum just means big hole. This is the chorda equina. Okay, so this is the horse's tail section around the sacrum and lumbar spine region. So all that stuff we looked at with the sacral plexus, lumbar plexus, this is where it's coming from. So now they've made an incision down the dura, and then you open up to see the cord. Okay, so you can see all the blood supply, and then there's the cord, and you can see there's nerve roots just here, And there they are, just there. Look, there's the nerve roots. And then that there, can you see that there, that triangle? That's the denticulate ligament. So you can see they're tooth-like projections. There we go. So they stick to the inside of the dura to keep the cord in place. So in the cervical spine, the nerve roots are angled slightly inferiorly. So we can see those. So you can see the bundles of nerves at the front and the back. So the dorsal nerves at the back, and then the ventral nerve roots at the front. And again, we'll explain these in a bit more detail as we go through. Yeah, so that's the direction of the nerve roots in the cervical spine. So we can see them there. So you can see these little filaments as they come off. This is the nerve roots in the thoracics. And then in the lumbars, they're directly down. Okay, so if we remember what we said about when in a newborn, the spinal cord fills the whole spinal column. So as a person grows, the cord stays roughly about the same size, but obviously all the vertebrae and all the muscles and all the limbs, they grow around that spinal cord. So what happens is all those nerves that are around the sacral region in an infant, they all get stretched. Okay, and that's why we end up with this cauda equina. So this is the horse's tail at the bottom of the spinal cord. And then we can see the strands, if you like, of the nerve tissue as it's coming down, and it will come off into the various different nerve roots. But look at that. It is like a horse's tail. Okay, so that's the cauda equina, horse's tail. And then there's the nerve roots there. So then we're down in the sacral region. So this was the region that we were looking at a few weeks ago. And this is the origin of those nerves around this area here. Okay, so there's your sacral nerves just there. Cool. Okay. Hopefully that's all okay so far. Okay, let's add a bit more on. So, yeah, spinal nerves are the communication lines between the spinal cord and then specific regions of the body. We talked about the number of vertebrae at each level. At each level, there are a certain number of nerves that originate as well. So in the cervicals, we've got 8 pairs of nerves, 12 in the thoracics, 5 in the lumbars, 5 in the sacrum, and 1 in the coccygeal, usually. Okay, so again, there are variations with those. The nerve roots, which we've just seen, so we see those things coming out of the side of the spinal cord, and you saw that there was one at the front and one at the back. So that top-down image where we saw them split was really useful. But they do different things. Okay, so there's 2 big bundles of axons, which are the name for the nerve tissue. They're called roots, and we've got an anterior or ventral, so that's towards the front, and then a posterior or dorsal, so like I said, the dorsal fin. These connect each spinal nerve to smaller things called rootlets, and we saw those on that last video where there were these tiny little strands before it became a root. Okay, now when it's at so you can't really make it out on this picture very well, but I've got a better image later on, but just for now we've got the dorsal roots just here. So these are coming out of the back of the spinal cord. These are sensory. So this particular section receives information from the body. Okay, so the posterior part of the nerve roots, so the dorsal roots, these are purely sensory nerves. Okay, so they're just receiving information. This bit here, and you'll see it on the dissection in a second, is called the dorsal root ganglion. And a ganglion is like a gathering of stuff. Okay, so you might have heard of like a ganglion cyst in the wrist. It's like a swelling. Yeah, so this is a swelling of sensory nerves. So there's more sensory nerves in this kind of bulb area than there is anywhere else. So the dorsal root ganglion is often referred to as the DRG. Okay, so you might have seen that in certain books and stuff. So that this area here is just a collection, like a bigger collection of sensory nerves, and there'll be a lot of transference of information around that particular area. Now this bit here, so this is the ventral part or the front part. This one here is purely motor. So this is information from the brain down the spinal cord and then out to whatever it is that that particular nerve goes to. So whether it's a muscle or whether it's a part of the guts, because it can be automatic, so it can be part of your autonomic nervous system, or it can be voluntary, which is part of the musculoskeletal system. Okay, so it can be stuff that you control or stuff that's automatic. So it could be a motor nerve going to the heart, for example, and you obviously don't think about your heart beating; it just happens. But the nerve impulse to the heart will come from one of these motor nerves. Okay, so at this point here, though, can you see where both the blue and the red join together? That's when it becomes the spinal nerve or the peripheral nerve. And at this point, they're mixed. So here, it's purely sensory. Here, it's purely motor. Here, it's a mixture of the two. And that's important later when we look at the effects of herniations and where the herniations are and depending on what's been affected. I was taught ages ago that the motor nerves are kind of on the inside and the sensory nerves are on the outside of the peripheral nerve. So if you have a kind of impact on the peripheral nerve, then the sensation will change first. But I now know that's not true. It's not as simple as that. Okay, so they aren't arranged in like an outer and an inner layer. Yeah, it just doesn't work like that. It's just completely mixed. So you can't glean information about the size of a compression on a nerve by the things that are affected. Okay, that's just not possible. It's way too simplistic. Okay, so yeah, these little rootlets that come in here and here, so the motor and sensory rootlets, they join the spinal nerve to the spinal cord. The posterior roots and the rootlets contain sensory axons, so that's this bit, so that's the blue bit, and the anterior roots and rootlets contain motor axons, and they provide nerve impulses to muscles, glands, anything that contracts, basically, okay, or needs some kind of motor input. So yeah, so that's the kind of structure around that region there. Let me just take you back to this one. Let's go this one. Okay, just going to show you this, and then hopefully this will make a bit more sense. No questions this morning. Always a stunned silence on this one. Okay, so we've had the spinous processes removed, and here's your spinal cord, and then these are the nerve roots, and then that's the dura on the side there. So let me just pause that there. Can you see these bits? Yeah, these tiny, tiny little bits of nerve. These are the rootlets, yeah, that we were just talking about. And can you see where they come together then to form one root? Yeah, so we've got all these little rootlets coming together. So you can imagine like the information that is passing up and down the spinal cord. And this is where they come through. Okay, let me just pause that there. So here we've got the vertebral body, one just here. You have a disc in between, and then on the side, remember there were those intervertebral foramen, so the holes on the side of the column where the nerves come out, and that is the nerve just there. So you can see it just there. Look, okay. Let's just bring this one up, Martin. So if sacral has 6 vertebrae, does it have extra nerve endings? Usually it will have 6 because the lumbars have 4. So it will usually have the same amount number, but they'll just be in a different place. Okay, but sometimes there may be more. I don't know of anything specific actually. I'd have to have a look, but yeah, basically, usually if you've got 6 sacral vertebra, you've usually got 4 lumbar, so the number of nerve roots will be the same. Okay, I would imagine if you had additional ones, then you would just have additional nerves, but I don't know for sure. Okay, and we'll have to have a look at that. So yeah, so here's your nerve coming out here. Yeah, so there's your vertebral, intervertebral foramen. This is a really good image in a sec. There we go, look at that. Cool. Okay, so there's your dorsal root just there, and then the ventral root at the front. So we're anterior and posterior. So remember, dorsal was sensory and ventral was motor. So these rootlets will be sensory nerves, and those ones at that bit there, those will be motor. And then they'll come out, and they've chopped a bit of the side of the vertebra off there, so you can get a good view. But they'll come out and then form a mixed nerve root. Okay, so there's the ventral at the front, and then there's the rootlet. Okay, there's the dura. You can see it's continuous with the nerve root to protect everything. And here it comes here. So there's the dorsal root ganglion, so the thickening of the dorsal region, or kind of swelling of that region. And then they're coming out there, look. And then you see that one there. Let me just pause that there. Just go back a sec. Just pause it right at the right time. There we go, perfect. So at this point here, as it's coming out, and it's now peripheral nerve, this is now a combined nerve. So this is a mixture of motor and sensory axons. And then can you see that one there coming out there? So these are called rami, and a rami or a ramus means a branch. So we've got a posterior branch of nerves and an anterior branch of nerves. So this one will come off and supply maybe the limbs or whatever part of the body this is, or the front part of the body. This one here will go directly to the back and supply the skin and the muscles that overlie the back of your spine. Okay, so that one will just go straight back, yeah, go straight to the skin over the spinous processes and the muscles that are there as well. Yeah, so that's posterior rami, anterior rami. So these are the branches. And then, sorry. And then the posterior rami, it's sensation and motor for the muscles. Let me just pause that again there. There we go. Sensory and motor for muscles directly on the posterior aspect of the spine. Okay, so you can see the spinous processes there. So that branch there, that's a mixed nerve as well. Okay, but you've got an offshoot coming away to supply the muscles and the skin on the back. Okay, and then this one here, this will go towards the front of the body. Just pause that there. Okay, so this one here, anterior rami, so this is to the rest of the body. That one just posterior, this one the rest. And you can see the different sizes as well. So if I just go back there, see that one's quite small and that one's really chunky, which makes sense because if you've got more muscles to innervate, more area of skin to receive information from, organs or whatever it is that those nerves supply or receive information from, there's going to be more of them in the anterior part than there is in the posterior. So the nerve branch that comes off will be smaller or bigger, depending on what information is needed. Okay, so we know that area there is going to supply a larger region of the body. Okay, cool. So hopefully that now makes this a bit make a bit more sense. So if I just put myself up here, so this is the usual view that you'll see in a anatomy textbook. So we've got this butterfly shape in the middle, and then we've got the white matter, so the grey matter in the middle, and then the white matter around the outside, and then the nerve rootlets coming off of the spinal cord, and then this is the dorsal aspect, so the posterior part of the cord, so that's the dorsal root ganglion just there, so that's the swelling of sensory nerves there. So what we've got is so see here where we've got a cell body of sensory neurons. We've got nerve impulses for sensations coming in. It's going to the posterior part of the spinal cord, and we've got these cell bodies here, and there'll be a collection of those cell bodies, and that's why there'll be this swelling, so the dorsal root ganglion in that particular region. Then it will synapse, and then we'll have an interneuron, okay, which then may synapse with another motor neuron and send some information directly out, or it may jump to another level and activate something else. Okay, so we've got these information networks traveling up and down or across, depending on what the information is. Now, the grey matter in the middle, the reason why it's grey is because there are more neurons or more axons in this particular region. Okay, so the white matter don't have as much cross linkages between the neurons, so there's lots of interneuron connections in this grey matter, and it's denser, and that's why it's grey. Okay, so a lot of information passing to various different parts of the body within that grey region. So we talked about cauda equina before. So usually in the infant spinal cord, it fills the vertebral column. The spinal nerves exit through the adjacent intervertebral foramen, which is what we've just seen. And in the adult, the conus usually lies at the level of L1, L2. And we talked about that before as well. This means that the lower nerves, the lumbosacral and coccygeal, get stretched and then form the cauda equina, which is what we've just seen. Okay, so that's why we get that horse's tail appearance. Now, with cauda equina syndrome, this is something that I put together a little while ago. It's one of the reasons I came up with the idea for something called safety net, which is basically if someone has some suspicious symptoms, they may not be kind of full blown. There may just be like, this is a bit of a red flag. But there's only one symptom that they have, so you wouldn't necessarily, you'd be concerned, but you wouldn't necessarily be going, right, you need to go to A&E right now. Okay. So what I did was I put this together, and I said, look, if you've got lower back pain and you've got pain down the backs of your legs, and you have any of these sensations, and I give them this card, basically. I give the patients this card. I say, look, I don't want to worry you, but if you have any of these, take this card with you to A&E and say that you've been having lower back pain and now you have these symptoms. They should emergency MRI you. Okay, so that should be the procedure. So the cauda equina is formed by the nerve roots distal to the level of the spinal cord, so usually L1, L2 that we were talking about, and cauda equina syndrome is caused by compression of those nerves. So all of that horse's tail area, there may be something going on from L1, L2 and below that is causing a compression of the nerves. And those nerves supply the genitalia. So remember all the stuff that we were talking about with the sacral plexus, lumbosacral plexus, genitofemoral nerve. So you may have a loss of sensation around your bits, around wiping your bum. You might not be able to feel that sensation. You might not be able to control the anal sphincter. So we were talking about the levator ani muscle. and how that's innervated when we looked at the pelvic floor. So if there's a problem with the cauda equina and those nerves are being squashed, then it can affect your how it feels to go to the toilet. Okay, so you may have urinary urgency, or you might feel like you need to go but you can't go, or you might feel that you can't stop yourself from going. Okay, so there'll be changes to your bowel or bladder habits, and these are the things that we need to look out for. And it's from a book. I can't remember the lady's name. I'll post it in our group, but it's called Red Flags, basically. And these are the things that we need to be concerned about. So if we just take a couple of these, so loss of feeling, pins and needles in your genital area, increasing difficulty when you're trying to stop or control the flow of urine. So it may be stuff where people don't put two and two together. So they've got lower back pain and they've had these symptoms in the genitalia, or they've having trouble going to the toilet, but they haven't linked it to their back pain. But you need to ask the questions. Okay, so if someone has got back pain, you should be asking these questions every single time, because if you don't ask them, they won't tell you. But if they don't have these symptoms and you're still a bit concerned, you can give them this card and you say, look, if you develop any of these symptoms, go to A&E straight away. And it's called a safety net. Okay, so we safety net them. So the compression around the cord, or the cauda equina, can occur because of trauma. There may be a vertebral fracture or a displacement of the vertebra, so a spondylolisthesis where it slipped, a disc herniation, which is what we were talking about previously, a tumour, or a metastatic deposit or an abscess. So there could be a cancer spread or cancer growth, or an abscess, so a fluid buildup for whatever reason, some kind of infection. So there's lots of different reasons why you might have cauda equina. But if you don't get seen quickly, you can have permanent neurological damage, and you will lose the sensation permanently, or you will lose the motor control permanently. So it needs to be dealt with really, really quickly. Okay, so this is an urgent treatment, which is critical. So that's why having this card to give out is a useful thing to have. Okay, so hopefully that makes sense, and hopefully now you've seen the region, then you understand why it's such a problem. Okay, now I've just noticed the time that has just flown by. Okay, so here we go. There's the lady, Sue Greenall. Okay, so that's who wrote the book, if there is a metastatic spread, so cancer spread to the cord, and it's compressing the cord, then these are the kind of symptoms that people will usually complain of. Okay, so if they've got just one, it may be enough to raise your suspicions and you need to go to A&E. If it's kind of mild, they might go to A&E and then just be sent back again. So that's why that card is really useful, because they won't understand why changes happen. So if they know what to look out for, then they can keep an eye on it themselves as well. Okay, cool. Okay, so we're going to leave it there. We'll pick this up next week. Going to have a look at a bit more of the spinal anatomy next week, and linking some of the other pathologies for this region as well. Hopefully that's useful for a start for you. Okay, so we're talking a little bit about cauda equina. Yeah, we will see you next Monday at 10 o'clock.